Okay, so thank you very much, folks, for joining us and listening to our first podcast. Today we're going to be talking about Osteitis pubis, and we're going to be discussing it with experienced MSK sports physiotherapist Rory Jack. So the reason we invited Rory onto the programme is I did a placement with Rory at the Scottish Premiership football team, Hamilton Accies, and during the time I spent with him, I saw him managing a player who had Osteitis pubis, and so I thought it'd be handy to get him onto the show and just to quiz him about how he managed that and to pick his brains on that topic. So first of all, my name is Bruce, and I've also got
Thomas. I'm Thomas here.
Thomas. Brilliant.
Yeah.
So we'll just ask Roy, just give a kind of brief introduction of yourself just now.
Yeah, thanks guys. I graduated in 2011, spent probably 2.5 years doing my junior rotations through the NHS, spent probably the best part of 18 months doing MSK, when I moved to private practice with the aim of trying to get a wee bit more exposure to sports-related injuries. Started a master's probably about 3 years ago in sports physio, and that kind of enlightened a passion of mine to go and work in professional sport. So I've had a couple of jobs as a physio for a couple of professional football clubs over the last 2.5 years, which has more recently taken me to, as you said, Bruce, Hamilton Accies, which I thoroughly enjoy.
Brilliant, perfect.
Right on.
Okay, and so for now, just before we ask some questions on to Rory, we're just going to have Tom's going to talk around the anatomy around Osteitis pubis just now.
Yeah, so it's kind of I'm going to give you a little broad perspective and then go a little bit more specific. But Osteitis pubis generally insinuates lower abdominal or groin pain developing from hypermobility of the pubic symphysis, degeneration to the symphyseal cartilaginous disc, and stress response in the perisymphyseal bone. Further, in athletic individuals, osteitis pubis can be described as painful overuse or stress injury of the pubic symphysis and perisymphyseal bone due to chronic overloading. These overloading stresses can lead to differing biomechanics, creating core muscle injury as well, which has been shown to lead to symphyseal instability. I should mention that there are other causes of osteitis pubis, such as rheumatoid arthritis and pregnancy and infection as well. And there's other things. In terms of today, we're going to be discussing more of the athletic side of things. And these injuries can kind of be further pronounced due to the eccentric forces and high occurrence of change of direction in team sport athletes like football players, where they're sprinting, they're cutting, they're jumping, they're changing direction all the time. So that's kind of our anatomy and our background to this. And I believe now, Bruce, you're going to ask our first question to Rory.
Great, thank you very much, Thomas. Okay, so Rory, thinking back to that player that you were managing in summer last year, could you please recall for us what was the early presentation for that player, and what was it that led you to eventual differential diagnosis of Osteitis pubis?
Of course, so I think as with many things around kind of the hip and groin particularly, your history of presenting complaint and subjective features are absolutely key in terms of coming to your differential diagnosis. So with that in mind, I think it's quite important for me to give you a bit of a context to the background of this player. The player signed for us from another Scottish Premiership club at the end of the summer transfer window. So he probably started training with us in September. Now, importantly, he hadn't had much game time with his previous club. A lot of his competitive minutes came from loan spells at lower league clubs. And as you talked about, Tom, the kind of nature of these types of injuries, it's about intensity really, so kind of a lot of change of direction, accelerating, decelerating. This player, centre midfielder, very high energy player, and his main responsibility in our team was to break up play, get possession back, or just be a nuisance to the opposition really. So that involved a lot of kind of change of direction, accelerating, decelerating, and he could probably get away with that with less intensity, with no disrespect in lower leagues, but it was probably a step up in intensity when he came and started playing regularly for us. Another interesting feature, as you'll know, Bruce, is we train and play on an artificial surface. And whilst there's a lot of kind of debate about its role in injury risk, there is a lot of evidence to suggest that the friction and therefore the forces associated with changing direction and things on these surfaces is greater. So around about that context, there's probably an element that says, well, the load through this player's body as a whole was greater than he was probably used to. So as I said, he started training with us in September. He quite quickly became a regular in our team. He played most games 90 minutes through October, November and December. And as in many team sports, December is a very busy schedule. I think we played 7 games that month. And at the end of the month, it culminated in 3 games in 8 days, I think. And it was at the end of that kind of period of time that he reported eventually left lower abdominal related symptoms. Because of the context which I described before, he was very much enjoying his football. He was an important part of the team, which he hadn't been before at the level that he was playing at just now. Therefore, there was some reluctance for him to disclose these symptoms to us, which, whilst we may disagree with that, we can totally understand the reasons behind it. But he presented this, like I said, left-sided lower abdominal symptoms, and it was quite variable in nature. Sometimes he'd describe a warm-up effect, whereby he'd be doing the warm-up and he'd maybe be struggling with that acceleration, that change of direction or going over hurdles, and over 15, 20 minutes or so, it would generally get better. Sometimes it would get progressively worse. A consistent feature was that it was worse for a day or two after games. And it was also consistently affecting some aspects of his activities of daily living. So things like getting in and out of bed, so lying to sitting or sitting to lying. And also consistently when he coughed or sneezed, he was getting this left-sided lower abdominal symptoms. Objectively, certain features, as you'll know, Bruce, from the time you spent with us, we very much assess hip and groin patients within a layer concept. So we're looking at their functional movement, we're looking for any intra-articular sources of pathology, extra-articular sources. And without going into too much detail with that, some features that we found there was that he definitely had reduced hip extension bilaterally through a reverse lunge. In any sort of functional tasks, he was very much favouring an anterior pelvic tilt, and that was a common feature. And when you speak about anatomy like you did, Tom, we're probably thinking that's adding some compressional and maybe even tensile load, particularly around his rectus abdominis, going into the pubic symphysis. There wasn't anything of note kind of intra-articularly, but extra-articularly, as is consistent with a lot of these hip and groin presentations, there was a real mixed presentation going on. So we had some positive hip flexor findings in terms of resisted straight leg raise. We had some significant positive adductor symptoms around resisted adduction in various degrees of flexion, so at 0, 45 and 90. He was also painful and resisted adduction from an outer range position. And more specifically to this presentation, he was showing signs of abdominal related symptoms, so on a resisted sit-up. And our differential diagnosis, as you were asking, Bruce, has really come as a combination of all of that. He had symptoms which were very much consistent with abdominal related stuff, so things like his activities of daily living, like I said, his lie to sit, sit to lie, his coughing, and that alongside a mixed presentation, including abdominal related symptoms, kind of really led us towards thinking, okay, we're dealing with a more abdominal related condition.
The red herrings, thank you.
Not, well, I think the more hip flexor related and adductor related positive findings could certainly have taken us down a different path there. And what was interesting is the context of him as a player and also what we were doing. We were fighting relegation. He had become an important player in the team. He continued to play with these symptoms. Whether that was right or wrong, we can discuss that later. But his symptoms were getting worse. He started developing symptoms more consistent with pubic symphysis related conditions, so your pubic symphysis stress tests. And that probably more kind of specifically led us towards a differential diagnosis of pubic symphysis related groin pain. We eventually did get an MRI of that player. which showed signs, as you were discussing, Tom, about bone marrow edema or stress response across the pubic symphysis. He had that. It ruled out any other origin of pain, any other source of pain. So that MRI, in conjunction with his clinical features, really kind of was a clear clinical presentation here that we're dealing with a pubic symphysis related groin pain.
I was going to ask, how long kind of of a time period did it kind of take you to consider that was necessarily what was going on?
So he presented to us at the end of December, and we then had a winter break. So we had 3 weeks without a match, but we probably had about 10 days to decide a management plan here. So the symptoms didn't really change in that 10 days. And based on the initial assessment, we were quite confident we were dealing with an abdominal related groin pain, but could we be confident that was from a pubic symphysis origin? Probably not. We probably also considered kind of inguinal sources of pain. But he continued playing, so that was December to May, and it was probably about March time when he was really significantly struggling. Gotcha. He had these positive pubic symphysis stress tests, so that was probably over 2 to 3 months of playing at a high level. We were assessing someone there who was presenting with a 2-week history in the first instance. It's probably rare out with a sports environment that you're going to have that, as people will generally try and manage themselves probably for several months. Certainly when I work in private practice, these types of cases, from a personal point of view, I'd be encountering when they're maybe 5-6 months after onset, and that's when it becomes really challenging to try and manage them.
Pretty much that chronic stage, yeah.
Yeah.
Interesting.
Very good. Okay, and Rory, I remember when I was there, you're using quite a specific protocol to aid the players' recovery and rehab. So I was just hoping that you could kind of run through that for us, if you could.
Yeah, absolutely. I remember what you're talking about. I think it's probably a good time to mention the work of, there's a paper, lead author Stephen McAleer. I think it's published in 2015. The title of it I've got in front of me is The Management of Chronic Recurrent Osteitis Pubis, or Pubic Bone Stress, in Premier League Footballer, Evaluating the Evidence Base and Application of a 9-Point Management Strategy. That's a case study, however, very, very thorough, and I'd certainly recommend anyone who's got an interest in these types of presentations to read that, talking about the assessment and management of these types of conditions. Like I said, it's very thorough. A lot of it probably did agree with my clinical biases, and therefore I was quite happy to use that in clinical practice. Some of it maybe less so, but there's 9 points it discusses, like acute management, improving range of movement kind of globally, hips, pelvis, thorax, looking at adductor strength, looking at your functional movement patterns, your core stability, your lumbopelvic control, your gym-based strengthening, and your field-based conditioning and rehab. And whilst that's maybe not going to be relevant to everyone who's in front of us with this type of presentation, if you have that as a basis for your kind of management plan, and you choose what's applicable to the patient in front of you and what isn't, I don't think you can go far wrong when using that type of management strategy. So that's what we used. From our assessment with the player in question, we identified some kind of functional or biomechanical things that we could maybe improve upon. Like I said, this patient was really kind of predominantly in an anterior pelvic tilted position with a lot of his kind of functional movement tasks. So that's something we wanted to address through rehab. I think, as I described before, the load which his body was kind of having to deal with was probably a lot higher to what it was kind of normal for him. So really, for our rehab point of view, we had to offload him. We had to look at seeing if we could address some of those movement competency issues around about his pelvic tilt, whilst also looking to focus on his ability to control his lumbopelvis region and maximise range of movement across the hip, pelvic, thorax, because we know by doing that it's going to make him kind of globally more load tolerant. So the kind of protocol that you were discussing before is outlined in that paper, Bruce, and it talks about an acute phase, a pull-based phase, and then a return to kind of pitch-based stuff so early, middle and late. So there's 5 phases within that. And in my opinion, the most important phase of that is your acute phase, the goal of that being reducing pain. That's because, as we've discussed, this is probably to be treated similarly to like a bone stress response. And if you don't allow that physiological response, then if you start progressing too early, you're not going to achieve the outcome that you're looking for. So in our case, we had a player in front of us who was managing these symptoms for, I think we said 5-6 months. I think it probably took about 6 or 7 weeks for us to progress from that acute phase, so that pain reduction phase, into any sort of kind of loading phase. Now, had we managed that more aggressively at the start, then you might find that your acute phase maybe only lasts 10 days to 2 weeks. And I think that's a consistent thing with this type of presentation, is if the longer the symptoms are going on, or the worse they're getting, the more irritable they're getting, the prognosis is generally going to be poorer. And that kind of comes into the context of how you're going to manage it. So we spent about 7 or 8 weeks in this acute phase, whereby we're really looking to address those functional rehab goals that we spoke about, whilst maintaining some sort of conditioning through, be it a bike or a cross trainer. But ultimately, your criteria for progressing into your pool-based work will be pain-free ADL. So we spoke about the coughing and him getting in and out of bed. Your pubic symphysis stress tests. So that's in a Thomas test position. There's four tests within that. So you're in a Thomas test position. You're passively bringing the patient into end of range extension. You're passively bringing them into abduction as your second test. Your third test would be resisted flexion from that end of range extended position, which was your first test. And your fourth test would be resisted adduction from that end of range abducted position. And really that's just a pain provocation test.
And we do that bilaterally as well? Bilaterally
as well, yeah. Interestingly, the first time I've seen it, but doing that test on his asymptomatic side was bringing on his symptoms in the lower abdomen. And they talk about that being quite a provocative test for the pubic symphysis. So I'd advise caution in your highly irritable patients there in the acute stages, because that can stir things up, it can have a negative effect.
How often were you doing that, Rory?
So, good question. I think in the paper that talks about doing that as a daily test. I was generally only doing that twice a week, weeks maximum. And I would be doing it one, to make sure he's responding appropriately to the intervention that we were putting in place for him, but two, if we'd expose them to a new stimulus, be it pool-based jogging, for example, and we'd be looking to see how he's tolerating that load and looking for change in that as well.
So basically, just to make sure you're not aggravating symptoms, essentially.
Yeah. Nice. So your objective markers throughout this whole process are pretty similar. So your pubic symphysis stress tests, your adductor squeeze. So we spoke about that at various ranges of flexion. As you've seen, Bruce, I call it the SQ45. I'm not sure if that's what it's actually called, but it's with a sphygmomanometer in between the patient's knees and getting them to squeeze it as hard as they can at 0 degrees flexion, 45 degrees flexion, and 90 degrees flexion. The paper I mentioned before talks about doing it at 30 degrees flexion and 60 degrees flexion as well. And what you're looking for there is, are you getting any pain response, firstly? And if so, where are you getting that pain response? Is it before their maximum power output? And you're also looking for what is their maximum score on that. So in your acute phases, the paper recommends that the patient is achieving a score of 2.5 per kilogram of body mass. So for example, if the patient you're working with is 80 kilos, you'd be looking for them to be hitting a minimum of 200 millimeters of mercury for pain-free, for them to be progressing through that to the next criteria. Sorry, I said pain-free, but I think in the initial stages they allow you a intensity of pain of 1.5 out of 10 on your numerical rating scale. So there can be some pain tolerance.
I've gone 1.5 and not 2 or 1.
Yeah, I would generally go with 2 there as well. Other tests they speak about is a straight leg sit-up. And I would also, in terms of my battery of testing, I would be looking for a strength score in your adductors and your abductors. So looking to see what the ratio between adductor strength and abductor strength is. Some variability in the literature in terms of target scores there. Some suggesting as high as 1.2 to 1 in favour of the adductors, some suggesting it should be 1 to 1. Clinically, I would typically be targeting a score of between 1 and 1.1 to 1 in favour of the adductors. Wouldn't be doing that every day again, I'd maybe be doing that once a week.
Do you have a groin bar, Rory, that you use for that?
Yeah, so we got I think Valve Performance are describing it as a force frame now because there's loads of different tests you can do it, but we got the force frame, which we probably think is more reliable. We previously used the handheld dynamometer, which we found very useful, but in terms of reliability, you're getting at different scores all the time. The position of the patient is always going to be different, and we just think it's a little bit more standardised with the force frame, and the load cells are probably more reliable, but it comes up with the same data effectively.
Nice.
And as you progress through the stages of rehab, the objective markers are pretty much staying exactly the same, but the scores that you're looking for in the pool-based stage and the pitch-based stage, in terms of your SQ45 or your sphygmomanometer test, you're looking for 2.7. So instead of that 2.5, you're looking for 2.7 per kilogram body weight, body mass. So your 80 kilo patient, you're then looking to be hitting probably around 220.
Okay, so we need to get at least that figure, and it needs to be completely pain-free.
No, again, so that's in the early to mid stages, you're looking at a maximum of 1.5 out of 10. For your final return to play, the paper in question advocates that your pain intensity should be less on these provocative tests, so looking at a 1 out of 10 there. But really nice clear flow chart in that paper in question there. So like I said, I'd really encourage people to have a look at that and try it out with any sort of pubic related patients that you have in the future, because it's very, very valuable.
Right on.
Thanks very much. That was very comprehensive, informative, good stuff. And just our last question I wanted to ask of you was kind of the benefit of hindsight after going through all this kind of recovery and this player. If in the future you had a player that was to present like this again, would you manage it any differently, do you think? Or do you think you'd do pretty much the same? I know you talked about there, I guess when you're working with professional athletes, it's difficult because, kind of the medical ideal is probably different to what the club or team needs of the player and the players wants. What were your thoughts on that?
Yeah, I think a very important question. I think in this case we actually had quite a good outcome. The player managed to complete the season before we started his rehabilitation. He had a good season. It was his first season competing in the Premiership. He got a new contract on the back of it. The team obtained their objectives of survival in the league. So throughout that process, I'd often looked at my own practice and thinking, should we have pulled that player out sooner to make it a little bit easier to manage? But I think the context of that is the player was very motivated to continue playing despite his physical restrictions. The coaching staff were keen for him to continue playing, so a good outcome was attained there. I also think the player was back playing after 3.5 months. There's some figures that suggest that only 63%, I think it's 63% of athletes with pubic bone stress-related injuries return within 5 months. And of those, I think it's 41% are asymptomatic. So we actually had quite a good outcome there, and maybe that's something I would have done differently or would do differently in the future in managing professional athletes, is maybe just highlighting the risk of continuing to make these symptoms worse, because once you get too far into that stage of chronicity, as you described, the symptoms can actually become very difficult to manage. But as long as everyone's happy to take the risk, then no, I probably wouldn't have managed that one differently. But I think if you're then talking about managing a recreational athlete, the context probably completely changes there. Are you, and then even working with that athlete or recreational athlete, it's going to be, the resources are going to be significantly more restricted or limited compared to what you've got in a professional environment.
And contact time and frequency of contact as well.
I think, so ultimately, I think on that question, I think context is key. You need to think about what your opinions are, what the patient in front of you's opinions are, and as long as you can both decide on what's the best way going forward in a shared manner, I think that's the most important thing.
Awesome.
Thanks very much.
Yeah, really good. I think I had some other questions, but you really answered them all, to be honest.
That's a relief.
Bruce, I'm not sure if you have any more questions for Rory here.
No, that was all. That was all that I had. I think kind of you've outlined kind of in a lot of good detail.
Mm-hmm.
You know, how to spot. You know, how you came to your differential diagnosis, how it was managed, different objective markers that you use along the way,
mm-hmm.
and you know, you're saying you do much the same again if you had a similar presentation come up. Well,
it was nice to see that you had you used a paper to kind of guide you as well. You know, very evidence based as well, which is what you want, of course.
Yeah.
Mm-hmm.
Just for reference, sorry, Roy, what was the name of that paper again? Just one more time.
One more time. It's a long one. Management of chronic recurrent osteitis pubis / pubic bone stress in a Premier League footballer, evaluating the evidence base and application of a 9-point management strategy. The lead author was Mac Alear, who I think he's a physio at Tottenham Hotspur.
Okay.
It was published in 2015.
Right on. We'll probably attach that to our YouTube link when we put this up or something like that as well.
I would, because it's a very good paper.
Right on. For you, Rory, do you have like a blog or a Twitter account that we could tag you with this video to share to other people, or?
I've got a Twitter. I think it's. I'd have to check that actually. I'm not very active on it. I can pass it on, but I more use it to save future research or whatever I want to look at, as opposed to being too active on it. But I think it is a good resource.
Right on. Cool.
Thanks very much, everyone.
Yeah, thank you.
Time. That's been really helpful. And
thanks for inviting me on. I think it's a great idea what you are doing. So I hope you keep at it, and I'll keep a lookout with interest.
Right on, Rory. Thanks a lot. Stay safe in these times.
You too, guys. Take care.
All right. See you.
Thank you. Cheers, guys. Bye for now.
Bye.
Bye-bye.